Ladies and gentlemen, thank you for joining today's Global Vascular Guideline webinar session 2, focused on diagnosis and staging of the limb. This educational activity was partially funded by a block grant by W.L. Gore and Associates, and the concept and content was developed by the Society for Vascular Surgery. If you have not yet answered the questions in the pre-survey that appears as a pop-up window over your Zoom screen, please do so now, then hit the Submit button. You will need to scroll down to see all 18 questions, and you must answer each question before you can submit the survey. The pre-survey will be available for approximately 10 more minutes. If you have already submitted your answers, thank you very much. All presentations have been pre-recorded for today's webinar, and our presenters will be joining us live for the panel discussion segment. We encourage you to submit your questions for our presenters at any time by using the Q&A button at the bottom of your Zoom screen. Chat has been disabled for this webinar, so please use the Q&A button to submit any questions. Also, if you have not yet downloaded the Wi-Fi app, please do so now. And now, to begin the program, we welcome our Global Guideline Series moderators, Drs. Joseph Mills, John White, and Michael Conti. Doctors, the screen is yours.
Thank you very much, and welcome and good afternoon, everyone. Thanks for joining us for this webinar entitled Translating Guidelines into Practice, the Global Vascular Guideline on the Management of Chronic Limb-Threatening Ischemia. Today's session focuses on the diagnosis and staging of the limb. I am joined today by two excellent co-moderators, Drs. John White and Dr. Mike Conti.
Thanks, Joe. I had the privilege of moderating our first session last month, which was dedicated to applying the Global Vascular Guidelines for the initial medical treatment of patients with newly diagnosed CLTI. Rather than make it just simply a review of all available medications, we focused on a single sample patient to develop treatment strategies and demonstrate how the guidelines can be effectively applied by each of us in our own practice. We'll continue this educational approach today. To assess the value of these educational models, we ask that you please complete the pre and post-presentation surveys. We'll share with you the results of the surveys from the initial session at the end of today's webinar. Back to you, Joe.
Thank you, John. And just to whet your appetite a little bit for the next session, I'm going to ask Mike Conti to give us some more information about the third and final session in this series.
Thanks, Joe, and good afternoon, everybody. On October 10th, we'll have our third session in this webinar series, and we'll be addressing really where the rubber meets the road in the treatment of CLTI, which is how do we make clinical decisions about revascularization in an evidence-based and programmatic fashion. We'll be reviewing aspects of the guidelines concerning the global limb anatomic staging system and its utility for clinical decision-making, how to select a target artery path. We'll look at the impact of pedal artery disease, and we'll touch the bases on drug elution as well, with an outstanding panel of experts across the realm of CLTI revascularization. So please save the date for October 10th. That will be, I think, an exciting session for the series to conclude.
Thank you, Mike. The idea behind these three sessions was to help expand physicians' knowledge base and improve clinical confidence and effectiveness of treating patients with CLTI, which probably is the broadest spectrum of the most common disease that we treat. Today's webinar is Wi-Fi centric, and it's focused on hemodynamics and foot assessment. The importance of staging the limb at baseline and then repetitive staging during the course of therapy will be emphasized, because the plan may be altered depending on how the stage progresses as one goes through a sequence of care. We will describe Wi-Fi staging and review the use of the calculator. And so if you haven't downloaded the app yet, I encourage you to do so, because our first speaker is going to cover this very well. Our presenters will also review current approaches and limitations to the hemodynamic assessment of perfusion in the foot, how they are employed both pre and post revascularization. Finally, we will discuss how Wi-Fi staging drives triage and sequencing of care in patients with CLTI. Again, please download the app if you haven't. And as John mentioned, Rather than give a simple overview of appropriate medications or just a Wi-Fi lecture, we're trying to show how to put these guidelines into practice. So Wi-Fi was published almost 9 years ago. The global CLTI guidelines are 3 years old, and we've seen a pretty big impact of these already on practice. So we're going to run through a history of a very typical patient. I won't read it to you, but I'll highlight some key points while you look at the screen. So this is a 72-year-old man who still smokes, has hypertension, recently diagnosed type 2 diabetes, doesn't see a doctor very much, has had 1 to 2 block claudication for about 2 years, but he's not very active and rarely walks much further than that. A short time ago, he developed an ulcer over his left second PIP joint when he was wearing new shoes. He's been treating it with local cleansing and daily dressings without much evidence of healing. He has a remote myocardial infarction, but no recent cardiac symptoms. He's on aspirin, 81 milligrams a day, and metformin. He's got no reversible ischemia on his recent cardiac workup, which was performed after his inferior wall MI 7 years ago. Pertinent past surgical history, I think you can go to the next slide, Pete. He had a previous right great toe amputation for osteomyelitis 3 years ago, which healed. He's not systemically ill. He has a BMI of 29. His blood pressure is elevated at 165 over 103, and he's afebrile. He has some mild expiratory wheezing. The pertinent leg findings are that he has palpable femoral pulses bilaterally, and he has a healed right great toe amputation, which was performed a while ago. On the right foot, all the toes are pink and have good capillary refill. On the left foot, he has a shallow ulcer over the PIP joint of the left second toe. There's no exposed bone. There's no signs of infection. There's no redness. You can't see bone. It doesn't probe the bone. And there are no other areas of impending or actual breakdown of the skin on the left foot. There's no cellulitis. So he has palpable femoral pulses on both sides, but none distally. His femoral Doppler arterial waveforms are triphasic. His ankle brachial index in the affected leg is 0.56. His toe waveforms are pulsatile, but the pressure is reduced at 37 millimeters of mercury. And then as far as his labs, he has hyperlipidemia that's moderate severity, intermediate control of his diabetes with an A1C of 9%. So that's our patient. And then we're going to go through this patient, especially in how we use the Interactive Guidelines IPG app. So as a reminder, if Pete doesn't remind me, please answer your pre-survey so we can have a pre and a post survey before the session gets started. And then I'm going to introduce our first speaker, who is going to go through this patient and also how she uses the Wi-Fi calculator in her clinic. So our first presentation, we're honored to have Dr. Alina Quiroga. She's an associate professor of surgery at the University of Washington. She's board certified in vascular and endovascular surgery and practices primarily at Harborview Medical Center. She's a great advocate for trainees and believes in creating active partnerships with her patients to achieve the best possible outcomes. In fact, she recently was made the program director of their excellent vascular surgery training programs. She has a very interesting background. She earned her MD from the Universidad de Buenos Aires in Argentina. She's board certified in general and vascular surgery and is a fellow of American College of Surgery. She has wide-ranging interests, which include pretty much all aspects of vascular surgery, but she's especially known for her work in aortic disease, vascular trauma, and limb salvage. She joins us now with a pre-recorded session entitled Wi-Fi Staging and the Use of the Wi-Fi Stage Calculator. Alina, welcome.
Thank you so much for this invitation to discuss the Wi-Fi station and the use of the stage calculator. This is the second webinar when we have discussed the global vascular guidelines for the management of chronic limb-threatening ischemia. And if you look at the guidelines, the very second recommendation is to use a classification staging system, like, for example, the SBS Wi-Fi classification, to one extent the degree of infection and the degree of ischemia, to guide clinical management in all patients with suspected CLTI. And in which patient should we use this? We should use this in every patient with peripheral arterial disease that also have ischemic rest pain, or they have a diabetic foot ulcer or any lower limb ulceration that has been present for at least 2 weeks, or patients with gangrene involving any portion of the lower limb or foot. And remember, patients with venous ulcers, patients with non-atherosclerotic disease like vasculitis, patients with acute limb ischemia, or patients with traumatic wounds, those patients should not be staged using the Wi-Fi classification. So when do we use it? We use it at the very initial presentation, the very first time that we assess a patient with CLTI and tissue loss or rest pain. And we also use it over time, so we can measure the response to the treatment. And this is a typical example of an EPIC node when we are documenting, when we are assessing the patient, the Wi-Fi state, in this case at 221. So when talking with the podiatrist or the wound care or anybody is looking at this node, they know exactly why we're talking on this patient. So what are the components? The W stands for wound, I for ischemia, and foot infection. So the wound is classified in grade 0 to 3. 0 is no ulcer, a patient with no ulcer or gangrene, a patient with just ischemic rest pain. 1 is a patient with a small, shallow ulcer and no gangrene. This patient should be doing okay with either a digital amputation or revascularization and wound care. 2 is a patient with a deeper ulcer that have exposed bone or a joint or a tendon, not involving a lot the heel, or if there is a heel ulcer, it has to be superficial, or a patient with gangrenous changes that are limited to the digits. These patients will require multiple digital amputations or a formal TMI. And lastly, there are the patients with grade 3, the most severe classification. They have extensive deep tissue loss and ulcers involving the forefoot and the midfoot, or a full thickness heel ulcer, or extensive gangrene, those patients that cannot just be treated with a TMA. And this patient will require revascularization and extensive surgery in order to save that lower extremity. In ischemia, we also classify grades 0 to 3. 0 is a patient with normal ankle brachial indexes, and 1 to 3 goes with different degrees of ischemia. With most of the patients, we end up using the top pressures, as these patients are diabetics or have very calcified blood vessels. We cannot rely in ankle brachial indices to perform our station. And the most severe degree is a patient with a top pressure less than 30 millimeters of mercury. Lastly, we divide the foot infection in 4 groups. 1, the patient with uninfected, no sign of symptoms of infection. The patients in the mild group, they have a local swelling or induration, tenderness, pain, and if they have erythema, it's less than 2 centimeters around the ulcer. Patients with a moderate infection, they have a focal infection that involves skin and the subcutaneous tissue with maybe more than 2 centimeters of erythema. And if they have a deeper infection, there is no systemic inflammatory response. Patients with severe infections are those patients that are entering sepsis, that they have a local infection, but also a systemic inflammatory response. So with that, we can classify these patients in clinical stage 1 to 4. As you can imagine, 1 is the green, is the most benign, the most positive outcomes, and 4 is a high-risk patient, high risk of amputation, is the one that's marked in red. So how do we calculate a Wi-Fi score? And this is a hypothetical case that was given to us. It's a 72-year-old male with a 6-week history of a shallow left second toe ulcer. He's a smoker, has hypertension, had a minor cardiac attack a few years ago, and he was recently diagnosed with diabetes. He reported maybe a 1 blood claudication over the past 2 years, but he hasn't walked that much. He only taken aspirin and metformin, and you can see there a very shallow and clean ulcer. These are the non-invasive testing, and you can see that this patient has an ankle brachial index of 0.56 and a toe brachial index of 0.22. And his grade toe systolic pressures are only 37 millimeters of mercury. So what does it mean? How do we calculate his Wi-Fi score? So what I like to do, I go to my phone. I have downloaded the SBS app, and I can very quickly click on the SBS Wi-Fi threat and limb classification system, and I have a quick reminder of this, so I don't have to remind it all the time, all the values. The patient have a small shallow ulcer, there is no gangrene. I open the ischemia and I try to find out, and this patient was at 30 to 39 millimeters of mercury in the top pressure. Also the same level will be for the ankle and systolic pressure. And after that, we go to the infection grade. This patient was not infected, so we click in non-infected. And after that, we are going to scroll down, find out the calculator, and find out what is the Wi-Fi classification for this patient. As you can see, it's a Wi-Fi 120 for a clinical stage of 2. His amputation risk is low, and the patient have a moderate risk of benefit for vascularization. So what do we do for this patient? We go back to the guidelines, and the recommendation for this patient is to evaluate his cardiovascular risk factors and to work on all the modifiable risk factors. We're going to educate the patient in quitting smoking, going to ask him to continue aspirin. I am going to start rivaroxaban to prevent an ischemic event in patients with CLTI, and I will start this patient in statin therapy at the same time that we're going to continue working on his blood sugar control and taking his metformin. So the recommendation in the same guidelines will be to consider revascularization on this patient with average risk with intermediate Wi-Fi stage 2 and significant perfusion deficit. He's a Wi-Fi ischemia grade 2. So I was asked what I will do different if the toe systolic pressure was 22 instead of 37, and he barely have a toe waveform. And again, we go to the application, we see what is going to be the final classification of this patient, and when we calculate, now he's a Wi-Fi 130, and his clinical stage is 3. And his amputation risk is moderate with a high potential benefit from revascularization. So again, we go to the guidelines and we're going to talk to the patient, most probably do the procedure in a more urgent basis, start with an angiogram to find out what we can do to bring more blood supply to this leg so we can prevent a major amputation. The next scenario that was posed to us was what, if anything, we would change or do differently. Is now there is a 1 centimeter ring of cellulitis around the ulcer with yellow pus that is expressible from the joint. Now the infection rate have changed. He's not uninfected anymore. I will consider this a moderate infection. The patient doesn't have any sign of sepsis. However, there is a local infection that is going to the deep space. So when we calculate his Wi-Fi score now is 1 to 2. His clinical stage is 4 with a high risk of amputation. So what do we do different on this patient? I will start with urgent surgical drainage. I will do source control. I will start antibiotics. And after that, I will restage the patient. And most probably he will benefit anyway of some kind of vascularization process, but that will be after we have source control of this infection. And the last scenario was what, if anything, will change if the ulcer was clean, but instead was located on the second metatarsal head and will probe to the bone. And again, this is a deeper infection, a deeper tissue loss degree. We put all the variables in the calculator, and again, the patient has a Wi-Fi 220, his clinical stage is still at 3, and his amputation risk is moderate, and he will have a high benefit from revascularization. So I hope that you have a better understanding of the Wi-Fi components and can go down and download the Wi-Fi application. I found it quite useful, and we will keep discussing this with the next speakers. Thank you so much.
That was excellent, Dr. Quiroga. Now we're going to move on to Dr. Nobuyoshi Azuma, professor of surgery at Asahikawa Medical University in Hokkaido. He's a very distinguished vascular surgeon, was one of the co-authors of the global classifications, has done extensive work with the spinach registry, and Japan was one of the first countries actually to widely adopt Wi-Fi. He's going to share some data with us, some of which you probably haven't seen before, on the relationship between Wi-Fi staging and important clinical outcomes in patients with CLTI.
It's a great honor for me to deliver a lecture regarding GVG. I'm deeply grateful to Dr. Mills and Dr. Conte and SBS for this opportunity. I have nothing to disclose. This slide shows that the patient background varied greatly from country to country. In particular, our country has a very high proportion of diabetes and dialysis-dependent patients among CLTI population. In addition, the population is aging rapidly, and dialysis patients have a longer life expectancy compared to patients in the United States. In addition, the lack of podiatrists in our country mean that many patients receive revascularization at their highest Wi-Fi stage. Even in such different circumstances, we believe that GVG is applicable in Japan and have published a Japanese translated version of GVG in collaborating with SBS. Today, I'd like to explain how Wi-Fi classification is related to important clinical outcomes after revascularization, as well as the choice of revascularization method based on Japanese data. And I'd like to prove that Wi-Fi and GVG also useful in countries outside of US and Europe. This slide shows the result of a spinach study, a Japanese multi-center prospective observational study comparing the choice of between EVT and bypass for CLTI patients. The propensity analysis, including the Wi-Fi classification as a covariate, showed no difference between the two groups. Interaction analysis showed that patients with systemic factors such as renal failure and diabetes were more suitable for EVT. On the other hand, a patient with Wi-Fi grade 3, wound grade 3 and FI 2-3 were more suitable for surgical revascularization. Then we were able to propose factors that are suitable for surgical revascularization and factors that are not suitable for surgical revascularization. Such concept is also compatible with algorithm proposed by GVG, and I believe that it is one of major factors in the good acceptance of GVG in Japan. In our country, where there are no podiatrists, we believe that the community network is important to limb salvage, and we are using the communication app like this. This app has a template, so even non-specialists or nurses can upload foot photographs and register the ABI and SPP value and presence or absence of infection, so that we specialists can speculate the Wi-Fi stage of the patient. Ulcer healing is an important outcome related to cost and quality of life. This slide shows the wound healing and limb status after revascularization. Dark gray area indicating unhealed wound were more rapidly reduced in surgery group, which mean that the healing after revascularization in surgical revascularization group is much faster than that of EVT group. This slide demonstrates the result of single-center retrospective study trying to find out factors related to delayed wound healing after EVT. Several factors such as non-ambulatory status, hemodialysis, low EF, and Wi-Fi stage 4 are significantly associated with non-healing. Interestingly, glass IP grade had no statistically significant association with non-healing, whereas glass IM grade, inframalleolar grade 2, was an independent risk factor for wound healing. In my country, these three factors promote increasing complexity of arterial lesion. So how to evaluate and treat heavy calcified arteries and foot artery lesion due to long-term diabetes or chronic kidney disease has become a future challenge. Though the lower extremity is a locomotor organ, and gait function after revascularization is an also important outcomes, which is related to long-term survival. This slide shows the result of a single-center retrospective study in which Wi-Fi wound 3 was an important predictor of impaired ambulation after revascularization. This is one of the results of a SPINIT study evaluating post-operative status, again showing that high Wi-Fi stage is an important predictor for loss of ambulation function after revascularization. Quality of life after revascularization is apparently important patient-oriented outcome. Non-ambulatory status, renal failure, and high Wi-Fi stage have been identified as preoperative factors that may inhibit improvement of QOL after revascularization. Survival prediction has also been suggested by GVG to be important in the choice of revascularization procedures. As you know, the survival prediction model of CLTI patient derived from a very large US database has been developed. On the other hand, given the different background of patient, it may be useful to predict life expectancy based on data from one's own country. This slide shows a prognostic calculator that calculates 30-day mortality and predicts survival up to 3 years for each procedure based on data from SPINIT study population. The important thing to note here is that Wi-Fi grade, wound grade, and FY grade are important prognosis, important in predicting prognosis. And honestly, I was surprised when I analyzed this data that Wi-Fi affected not only the short-term prognosis, but also long-term prognosis. Now we have realized that high Wi-Fi stage is a strong negative predictor for ulcer healing, ADL, QOL, and survival after revascularization. We speculate that suffering from malnutrition and inflammation, prolonged bed rest, and delayed rehabilitation probably worsen those clinically important outcomes. In conclusion, Wi-Fi classification is widely used in Japan as common language by not only vascular surgeons, but also cardiologists and plastic surgeons. With the spread of Wi-Fi, The GVG also gaining wide acceptance in Japan, and the translation of the guideline has played an important role. Preoperative high Wi-Fi stage is strong negative predictor for clinically important outcomes, such as ulcer healing, ADL, QOL, and survival after revascularization. Thank you very much for your kind attention.
Thank you, Dr. Azuma. As a reminder, please use the Q&A button. I've answered some of the questions already. Next up, we'll hear from Dr. Sanjay Misra, Professor of Radiology at the Mayo Clinic in Rochester, Minnesota. He's interested in all aspects of peripheral arterial disease and runs an NIH-funded vascular biology laboratory. He's here with us now to discuss current approaches and limitations to the hemodynamic assessment and perfusion measurement in the foot and how we use them pre and post revascularization.
Good evening, everyone. My name is Sanjay Mishra. I'm an interventional radiologist at the Mayo Clinic. I want to thank the organizers for allowing me to speak to you. And this is my topic today. It's on perfusion imaging, a very long topic title. These are my disclosures. And the learning objective for this talk is to review current approaches and limitations to hemodynamic assessment and perfusion measurement in the foot, and how they're used pre and post revascularization. And so this is our patient and some of the data that was discussed earlier. And as we look at this, this is a patient with ischemic toes. And the non-invasive studies are guiding us as we make a decision on how to manage this patient. And this is being discussed earlier today. And the vascular lab studies, the left ABI is 0.56 and the great toe pressure is 37 millimeters of mercury. And we have nice pulse wave recordings here showing that the femoral artery waveforms are triphasic and the popliteal and pedal waveforms are biphasic. And so I would show you several guidelines. One of them was written very eloquently by Professor Conti and colleagues. And this is the other one that sort of discusses management of patients with lower extremity PAD, the American Heart ACC guidelines. And this is the CLI algorithm and how to approach patients with critical limb ischemia or CLTI. And so patients with CLI and ABIs that are diminished, abnormal ABIs of less than 0.9, if you follow this, you can see the recommendations for perfusion are TBIs, TCPO2s, and skin perfusion pressure measurements. And then depending on how you will manage this patient, there is also recommendations on assessment for anatomic assessment. And that's listed very nicely. So there was a statement that I had the privilege to chair a few years ago, and I'll speak to you about that. And this is basically a statement on perfusion assessment for patients with CLI and opportunities. And as you can see, there's a multidisciplinary group of physicians and scientists that participated. And so the current perfusion technologies that we have available to us, and this is in the practice, Table 1 really outlines them. ABIs and TCPO2s, those are really the hallmark of how we will assess patients such as this. And then there's also skin perfusion pressures, and there's recommendations. And what's nice about this, it gives you a sensitivity and specificity, and also gives you the limitations. So obviously ankle brachial indices are very difficult to manage in patients that have calcified arteries. And so they can be abnormal. TCPO2s, which we use here at Mayo Clinic Rochester, have also problems, especially with patients with open wounds, edema, and amputations. And then skin perfusion pressures are reproducible. Reproducibility is a limitation. Pain can be a limitation, and then there's artifacts from motion. The others are more investigation or early biosensors that are phosphorescence based, and then ICG as well. So these are the thresholds when we look at for predicting wound healing. We want an ABI of greater than 0.45 in general. We want TBIs greater than 0.75. And then we want toe pressures greater than 70 millimeters of mercury or greater than 30 millimeters of mercury increase after therapy, such as a surgical intervention or a endovascular intervention. And then the TCPO2s, by and large, we would like to see them higher than 40 millimeters of mercury, and then SPP greater than 30 millimeters of mercury. So these are numbers that we use clinically, and these are numbers that we use clinically after an intervention or even to help predict a patient needs an intervention. These are the different technologies that are research applications. Again, you'll see indigo carnitine angiography. And this is a nice application, but it's, it's hard to understand. It's invasive. It lets you evaluate microcirculation. CT perfusion, we've tried that at our institution. This, again, is to quantify perfusion. And this is mostly in the setting of preoperative imaging. But again, you've got cost, you've got radiation. And the others are MRI, gadolinium kinetics, fold ASL. Again, perfusion, imaging based, but these take a fair bit of time and the patient needs to lay still. And then finally, there's contrast enhanced ultrasound and hyperspectral imaging, all early imaging. And so here's an example from Dr. Sumpio's paper of a technique using spectral imaging, and it's a non-invasive technique, and it shows you the angiosomes on the left. So if you're an angiosome revascularization person, it really outlines that very nicely. And then it shows you the changes after intervention, pre-intervention, 10-minute after, and then 60 minutes after. One of the challenges of this type of a therapy is that it would be nice to have something on the table that we could use as we're doing interventions. Here's a second example of a Indocin green fluorescent imaging, something I've not used, but it shows you time to perfusion and gives you different curves, and it allows you to look at microcirculation, an experimental or very early preclinical test, and it's talked about. I'm not sure how much it's used. I would love to hear what the panel thinks. And here's spectral imaging. This lets you look at deoxyhemoglobin and correlates with PAD and diabetes. And the nice thing is it doesn't use ionizing radiation. And these are examples of patients on the left panel that have no PAD and the patients on the right panel. So then, again, early evaluation. Probably the imaging modality that I think is almost ready and can be used for imaging patients while you're doing intervention is perfusion angiography. And there's several papers on this, and I'll sort of spend the last few minutes talking about it. So perfusion angiography and how it works. So it's a DSA application that's used on a Philips machine. So if you have Philips at your facility, this may be something that you may want to try. And what it basically does is time density curves from first pass of contrast agent. And there's some post-processing that goes on. And this has been described for stroke, myocardial infarction, and tumor perfusion. So this is one of the keys to this. You need to position the patient and he or she needs to be compliant and lay still. And so you need a dedicated footrest for immobilization during perfusion angiography. And here's an example. And this is what you get before and after. So the figure 3 is a patient that had popliteal angioplasty for CLI or CLTI. On the left panel is before. on the right panel is after, and what you get are these curves that show you time to perfusion, and you can see that they can really be quite nice to interpret. Here's a more dramatic example. In the bottom panel, a patient that got a perineal intervention for CLI before and after, and you can see that the curves separate nicely. So again, showing you that you've got better perfusion after intervention. And then here's another example of a patient before and after perfusion angiography with their associated time curves. The upper panel is pre and the lower panel is post, and this is a combination multi-level SFA and anterior tibial intervention showing nice perfusion changes after intervention. So in conclusion, perfusion imaging has lots of promise for interventionalists and people doing procedures. I think a on-the-table perfusion technology is really important. It can help guide interventions, especially endovascular interventions, what to intervene, when to stop. And I think the future of this really needs to be correlated with what happens with clinical improvement and how this can guide interventional techniques. Thank you very much for your time.
Thank you, Dr. Misra. A lot to discuss there when we get to the panel part. I'm proud to introduce our final speaker, with whom I was honored to work for almost a decade in Arizona, where we founded SALSA. His many accomplishments are too numerous to list, but he has produced more than 600 peer-reviewed research papers, over 100 book chapters, founding editor of the American Diabetes Association Clinical Care of the Diabetic Foot. He was the first podiatric surgeon to become a member of the SVS and the first podiatric surgeon named a fellow of the Royal College of Surgeons in Glasgow. He's got many more accomplishments, but he's an excellent speaker, and he's going to talk sort of about the philosophy of Wi-Fi and how Wi-Fi staging drives the triage of care in patients with CLTI. So welcome, David. Thank you.
Ladies and gentlemen, it is such a pleasure to be with you today, to be discussing really what hopefully is kind of a dynamic philosophy based on the global vascular guidelines to try to help hopefully keep a few more legs on a few more bodies. Ladies and gentlemen, we give away all of our slides. I just ask you to copy them, make them better, and pay it forward. You can ping me whenever you like for any of these. How does that sound? And we're going to really talk now really about a unified surgical approach based on three rings of kind of intersecting risk, really Wi-Fi made dynamic, because that's what it is, and that's how it works really, especially when you have kind of a toe and flow sort of limb preservation model. And so we're going to really have something of a tripartite, because things come in threes, as it were. 5 or 10 minutes together today. We're going to talk about three rings of risk, and in that area, we're going to broadcast our Wi-Fi settings. We're going to talk about a surgical philosophy focused on these three rings, both for wound or tissue loss, for ischemia, and for foot infection. We're going to look at a case or two for each of those. And then finally, we're going to talk about the diabetic foot in remission. We don't have time to talk about cases associated with that to extend ulcer-free days, but more just the philosophy, as it were. But the big idea here is when we're evaluating a patient, we really have to ask what is dominant. Is this a tissue loss dominant condition? If that's the case, well, close the wound. If it is an infection dominant condition, well, that often takes precedence. Get rid of the infection or address that. Is it an ischemia dominant condition? Well, address that. And these are all sort of intersecting rings of risk. And that's really what brings us to Wi-Fi. And what are we talking about? Many of you have seen this already, but let's just review our Wi-Fi settings, looking at tissue loss on the left, ischemia in the middle, and foot infection. So wound, ischemia, foot infection, making Wi-Fi. And just like with tumor node metastasis in cancer, we really have none, mild, moderate, and severe here for each one of these things, both for the wound, for tissue loss, none, mild, moderate, severe, as you see here. For ischemia, none, mild, moderate, severe, depending on if you're looking at hemodynamic or tissue perfusion related issues, and for foot infection, none, mild, moderate, severe, based on the Infectious Disease Society of America's guidelines. So that is the big picture here. The thing about this, though, is that these are always changing and they're always intersecting, and this is dynamic. And that's why the team has to be dynamic in an interdisciplinary sense in addressing these. But now let's talk about together as a family, if you will, maybe surgery, addressing wounds, infection, addressing ischemia, and addressing foot infection in that order. So if we're looking at addressing tissue loss, the big idea here is what causes diabetic foot ulcers or purely neuropathic ulcers in the face of neuropathy is pressure times activity. And that's what leads to this sort of imbalance that essentially allows a patient to wear a hole in his or her foot. And you have to bring that imbalance back into balance. That's the big idea behind any kind of surgery that you might be doing, trying to close up a wound, or at least in the reconstructive type, because there are really two flavors to non-vascular diabetic foot surgery, and those are reconstructive foot surgery and then just getting the wound closed. So let's just briefly look at an idea of a reconstructive type of foot surgery. This is a patient after a proximal transmetatarsal amputation, and you see his foot is in a varus position. And so you see here Tanzim Khan, one of my partners, at this time he was my fellow, doing a tendon transfer, just bringing that anterior tibial tendon over just to give it some good balance. And in doing that, you can bring something that is out of balance and probably not very functional into balance and be very, very functional so that he can have more activity as this patient, moves through his world. But another type of surgery that one can do in terms of tissue losses, wound closure surgery. And here we really have a couple of varieties. You have split thickness skin grafting. You see this done for a fasciotomy, but theoretically it shouldn't be much different than this done for a guillotine TMA, as you see here, or for a plantar diabetic foot wound, assuming that you can spread the force over the entire unit area, as you see here for this plantar foot wound that had a simultaneous tendon balancing and panmetatarsal head resection. And what you see here from data from almost a decade ago now is that indeed that is the case. For just about 100 patients, we saw almost 7 in 10 patients have complete incorporation of a skin graft, a 20% required revision, but that was usually pretty minor. And almost all of those patients that required revision were the sickest patients. They were those patients that had CKD stage 5 most commonly in this patient population. So you shouldn't feel like skin grafting is verboten to close a diabetic foot wound, especially after you've optimized the patient for ischemia and foot infection. And here you have a patient who has a wound on his posterior heel. He was scheduled for a high-level amputation. But instead of doing a skin graft, and you see me doing a partial calcanectomy here, my partner Keaton Patel at the time did a superficial circumflex iliac pedicle or skip flap. And this kind of free tissue transfer that is not very metabolically demanding can be really attractive in this patient population. And so that is yet another way to close these wounds. Now let's move on from infection, or I should say for wound closure surgery, to ischemia surgery. You don't need me to show this, but this is a patient of Joe Mills and me. And this is the angiogram beforehand. This is the result after Dr. Mills did an angioplasty, as you see here, beautiful, almost 70 millimeters of mercury of flow there. And now, after that, all we can do is just close that wound. And you see the skin graft here on this patient, which had a previously cadaveric leg and a BKA on the other side. And all she wanted to do was dance at her mother's, I should say at her granddaughter's quinceañera. And you see that happening right here. And there she goes. She's doing the salsa in the hallway. Almost fell, freaking out the nurse, but all is well. If these patients are going to get in trouble, we want them to get in trouble doing something, not doing nothing, right? So finally, just very briefly, let's talk about foot infection. This usually takes precedence over both ischemia surgery in terms of timing and wound closure surgery. But you see here, this is a patient that has that was referred to my partner, Greg McGee, who's on Vascular. He identified maybe a little bit of pus there dorsally. This tracked all the way up the leg. So you see here, this is a simultaneous procedure being done with my flow amigo, Greg McGee, who also did an angioplasty under the same anesthesia. That then was VAC'd and later converted 4 weeks later to a skin graft, which you can see here, step by step by step, wound infection, wound ischemia, and wound closure surgery in that order. We don't have time to talk about this, but I'll just briefly say that, looking at not just at foot ulcers, but their recurrence or ischemia and its recurrence is the flavor of the day. Nothing ruins a good surgery like follow-up. And let me just show you this. After 1 year, about maybe 4 in 10 of these patients are going to get another wound. It's about 2/3 at 3 and maybe 3/4 at 5. So recurrence, ladies and gentlemen, is not only common, it's darn near likely in this population. So if the foot in diabetes is a little bit like a cancer, and we haven't talked about that in this lecture, but if we look at cost and complications, one could make that argument that maybe when people are healed, maybe they're not healed, maybe they're in remission. And this is it sounds like a coin of phrase, but it's really, really important, because if you think about it this way, if we assume that this patient is going to get a recurrence of their wound in their long life, or a recurrence of their ischemia in their long life, then the goal here is to maximize those ischemia-free days and those ulcer-free days and activity-rich days for that patient population. So, ladies and gentlemen, in conclusion, we end where we started, with these 3 intersecting rings of risk, this sort of unholy trinity of tissue loss, ischemia, and foot infection. Our goal is to bring this imbalance really into balance, in order. And it doesn't stop when the patient leaves the operating room. It doesn't stop when the patient leaves the clinic. This is over his or her entire life, from the alpha to the omega. And here's to making a difference for our patients and helping them move through the world a little better each and every day. Ladies and gentlemen, thank you so very, very much.
So thanks to all of our presenters. I thought the talks were excellent. I would ask them please to turn their cameras on for a roundtable discussion. I've answered some questions in the chat, but Pete, did you have anything you wanted to say before we move on to the discussion?
We'll be opening in about 15 minutes. We'll open up the post-test, so I'll come back then.
Okay, thank you.
Do we have to also take the post-test as well?
You're not allowed to. It's a ringer. So one of the questions I'd like to hear from the different panelists. So one of the principles of Wi-Fi is you stage the limb. It's like T&M for cancer. So you wouldn't treat a cancer without staging it. And that was the idea behind Wi-Fi. And it's meant to give you, it's never going to be perfect, but it was meant to put people in risk categories to predict amputation risk. But also it was meant, as David outlined really eloquently in his talk about the 3 rings, as to which ring is dominant in this patient's presentation. So what types of surgery a patient needs to have, is diabetic and needs to have elective foot surgery, or they have a small ulcer and someone wants to debride it or do a hallux procedure. Is that okay to do, David, before you stage the limb, or do all those kind of patients need to have toe pressures first? And then which patients don't need toe pressures first?
I think that I think that the short answer to your question is that there is no answer. I think each person is their own. I think you really have to personalize this for every patient, and we don't want to just absolutely mandate that you get a test for every single patient. Although most of our patients, the vast majority.
Let's start out with a diabetic patient with a foot ulcer.
Yeah, so we almost always will get toe pressures on this patient population, unless they have really bounding pulses, and again, we're not going to be absolutely, led by these tests. We're going to be led by our physical examination, of the patient, and I think that's what we try to teach all of our trainees. But we'd like to get a picture of what's dominant here. If it's just a wound dominant condition, we may just get and really, really bounding pulses. We will still get the non-invasive vascular study, but we wouldn't hesitate to take a person to the operating room and debride them with that alone. If, of course, the patient had an infection, we still would get that test. But again, we're going to take them to the operating room, because typically that infection is going to supersede whatever vascular intervention is going to be done.
Yeah, Dr.
secondary.
Quiroga hit on that. So that's kind of the point I wanted to try to make is, so if you have severe infection that's drainable, that's the priority, right? If they have systemic inflammatory response, you need to resuscitate the patient, correct their hyperglycemia. Those patients, you probably will start antibiotics even though you don't have deep wound cultures yet because they're sick. But as soon as you've got them resuscitated, they need their foot drained. And then, so that one would be, you can stage the wound, you can stage the infection, but the ischemia grade might be indeterminate for that short period of time while you're getting source control, which shouldn't be more than 24 or 48 hours.
And by the way, that's what we put. That's what we'll put in our ischemia score. We'll say Wi-Fi. Maybe a 3 for the wound if it's a big wound. Ischemia pending, and then we say likely. 2 or 3.
I put P for pending or U for undetermined, but that's to remind you to go back and check. And
you
then
could buy a vowel or buy a consonant, whatever you like.
With the patients with a foot ulcer, the principle behind getting some kind of perfusion assessment is to avoid a systematic error. So how many patients have we all seen who had foot surgery, even a toe amputation that didn't heal, and they're referred with palpable foot pulses? And they don't have palpable foot pulses. And when you stage them, they actually have moderate to severe ischemia. So it's even a check on yourself. I mean, I think the more you get experience with these patients, the better your pulse exam gets, but nobody's pulse exam is perfect. So I think that's one of the principles too, is to avoid doing things that might make things worse before you're really sure what you have. Other comments? What do you guys do in San Francisco, Mike?
Yeah, I mean, I think we use, we're going to measure perfusion on all of the high-risk patients that have any foot wound and PAD, and diabetes. Unless they have really strong palpable foot pulses, and it's clearly, like David said, it's a wound-dominant problem or a pure neuropathic wound. The other reason to do it is to establish a quantitative measure. Because these patients who have risk factors are probably, as David said, they're likely to recur again later. And I think it's useful to establish a mark of where they are in terms of the state of their vascular disease.
Yeah, there was another comment which I thought was a really good one. We may veer us off a little bit, but so you stage the patient, you determine they need some type of revascularization, that's performed. When's the ideal time to restage them as far as their ischemia after your revascularization? So one of the things, let's get Alina to answer this one. So she mentioned that you should restage patients. So one of the principles, if you go back to the 9-year-old paper, is that it's just like cancer. If they get a course of chemotherapy, you restage them. And if they're not responding, normally you don't keep doing the same thing. You might switch to chemotherapy B, or you might switch to surgery, or you might switch to radiation. Same thing is true for the foot, right? So when you do a revasc, so let me back up. First thing is, once you debride the foot, the wound is changed, right? So they come in with wet gangrene of the third toe with a little bit of cellulitis on the bottom of the foot. And you have to do an open ray amputation, and you find out they have plantar fasciitis, and you make a giant incision on the bottom of their foot to drain it. That's no longer whatever wound grade that was when they presented, right? So they're upstaged. So that one's pretty easy. So they should have the wound regraded after you do something to it. But Alina, what do you find with your restaging for revasc? When's the best time you do either a bypass, are they different, or an endo procedure? Do you check it the next day? Do you wait a few days? What do you guys do?
So as I explained, we use it also as a common language with our podiatrists, with our wound care center, and if I'm going to refer a patient to hyperbaric chamber or something. So it's good to, after you revascularize the patient has the wound, I can discuss with my podiatrist and explain them what's the new classification now that the patient is revascularized but still has the wound and the infection is controlled. And the next moment for me is if the patient is not progressing as appropriate. So one is immediately after revascularization, and the other one is the patient is not progressing as appropriate, and we need to all come together to see why the wound is not healing or why there was a complication. That will be the second time to restage, to see what we are missing there.
Yeah, Dr. Misra, you talked about, you guys have done the Philips perfusion imaging. So have you noticed on the table that that some patients, for example, the best you can do is an indirect angiosome revascularization. Does that on the table perfusion measurement reflect what you might get in 5 to 7 days?
Yeah, so excellent question, Dr. Mills. I think we're a Siemens shop, and so we've tried Siemens technology using perfusion, and what we've done is combined it with CT. I didn't show some of that data where we've got a combined scanner and an angio table, and we're still working out the kinks. The Philips system has the best data published, and so I sort of thought I should show that. And as far as indirect angiosomes, we haven't seen much, we haven't done enough to really answer your question truthfully. So, but I think what we really need is, like I said, something that's reproducible on the table when we're doing indirect revascularization versus a direct revascularization, because often we're limited by anatomy and our endovascular tools to get the job done, and knowing when to stop is often difficult.
Yeah, I haven't had experience with that perfusion measurement because we don't have the equipment, but we have used Indocyanine and green, and I've seen it both ways. I remember a patient I did of David's when we were in Arizona where I wanted to get the posterior tibial open because he had a heel wound, and I just couldn't get through it. And that was before I was doing much retrograde access. So I treated his TP trunk and perineal, and I got the ICG-9, and took a while to get the tech there. And the improvement in perfusion was remarkable. I mean, if you had just showed me the angiogram, I would have said, well, you didn't do a whole lot because you can get the posterior tibial open. And I've seen other ones where the initial Indocyanine green doesn't look so hot. We had another patient together in Arizona, and then 3 days later, it looked remarkably better. So I think some of these people have choke vessels and collaterals in the foot that don't open right away. And I think some of it also depends on whether you have them under anesthesia and how cold the room is and how they're vasospasm down. So I don't know that I'd like to get something that we could use easily on the table to tell us when we're done. But I think for some of these things, it's unpredictable. And if you're not forced to do something to the foot, you should wait a couple days and assess maybe at 3 to 5 days. That's just my bias. If you're not forced to go ahead, especially if you're going to do a TMA or something, you better be pretty sure that you've maximize perfusion before you do that. A toe amp's different, I think. Dr. Azuma, what do you use in Japan? Do you use anything intraoperatively? And then if you don't, when do you get your test post-op?
Yeah, so thank you very much for asking me. So that maybe after revascularization, we need some minor operation to minor amputation or debridement. At that time, we also use ICG. And we understand, oh, this is a border of the blood supply or not. So that's a very convenient. Also, that the restaging of Wi-Fi is very important because delayed wound healing may be due to the infection or residual ischemia, or the restenosis of the EVT after. So that's a Wi-Fi restaging at that delayed wound healing patient. Then also we use ICG imaging on the operating room. Then decide the border of the blood supply. Yeah, thank you.
Okay, what do you do, Mike? Do you do anything different for bypass versus endo revascularization? When's the best time to assess perfusion before you deal with the foot, and is it different depending on your mode of revascularization?
Well, I do think after bypass, frequently the reperfusion is more significant, and typically in a well reperfused post bypass foot, there's edema, and the foot will swell and get hyperemic. And so I usually will wait a couple of days to let that all sort of clarify itself. You also can see demarcation better in the foot after a couple of days because the edema goes down. So I typically don't remeasure anything after surgical bypass for a couple of days at least. Doesn't mean I wouldn't do a tandem sort of minor toe operation if that's convenient. But if it's something more than that, or a forefoot amputation, I would generally wait a couple of days. I wanted to ask the panel, particularly maybe start with David, a little bit about how they use Wi-Fi to address urgency and sort of fast tracking patients, perhaps even who to admit to the hospital or how to get moving and how you do that. Because I personally believe that's an important aspect of the staging system.
Did you, were you asking me?
Yeah, why don't you start and maybe go around?
Oh, yeah, we'll start alphabetically.
Yeah.
Okay, so are you next after that, Mike? So I think the bottom line is that urgency is sort of graded based on the kind of the numeric. It really is by that numeric score, and if someone has a significant rip-roaring infection, that is going to take precedence over anything else that we're doing, and that tends to be dominant. And so what happens is we have this sort of, we call it instead of a foot hotline, we call it a hot foot line, and that's sort of engaged just like a stroke or someone was running a code, and our team comes down and descends on the extremity in the emergency department, on the wards, or sometimes in the clinic. And we try to do it together, but often you can't do it together. So you're texting while someone else is there, and it's usually a big mess electronically. But people are seeing this, someone on the toe side, someone on the flow side. And then you determine what's dominant there. And typically, if it is an infection dominant problem, then that toe portion of the team is the one that goes first and rapidly tries to get the patient in and into the operating room and drain the infection, temporize it, more of a damage control kind of situation. If it's a flow dominant condition, then the flow portion of the team is the primary clinician, and they're the one, and they will, treat the issue related runoff or inflow or multiple, but we're communicating constantly. And like I said, the communication is all happening internally. Internally, it may look like a big mess, but externally, I think it looks a little more elegant.
Lena, what do you guys do with a stage 4 patient in the clinic?
We don't do Wi-Fi before the patient gets to clinic, but I was listening to your question, and one of the main challenges that we have, I imagine almost all of you, is the patient that get referred too late, the patient that have been treated with antibiotic for 3 times, and when the patient didn't have palpable pulses, and that was the pendant rubber, and now they have dry gangrene. And there will be, now listening to your question, we're working exactly on that piece in the access to care and how to streamline the referral. If putting in our referral order or something, the Wi-Fi and an alert to be triggered. I don't know if anybody's doing that in the system, like either the rate of ischemia is more or something that the patient can be like trigger higher and taking a look higher in the system. And that with education of our referring doctors. And the way that we do with the patients in the ED is very similar to what David said. If the patient presents, we have a limb preservation team, it appears to be a more infectious problem. If the podiatry service or us are around, we will do the source control, that will be the first thing if the patient is septic or have a clear infection, and it's more an ischemic problem, we will go that road and see how we can revascularize the patient and do the wound care after.
Yeah, we're working on that. So we have an indigent hospital, the Ben Taub Hospital, that covers Harris Health, and we've tried to use Wi-Fi to streamline how patients, so Wi-Fi 4s get admitted. 3s, if they have grade 3 ischemia, get admitted. And if they come in late at night and can't get a toe waveform and pressure and that. So if you look at Wi-Fi carefully, in some patients, one of the grades doesn't matter because the other things may already drive it to a stage 4. So most stage 4 patients, I can't say all because there may be a rare exception, but almost all those need to be admitted regardless, especially if they're poor patients that aren't going to have an easy time getting back. So then the ischemia grade may drive at what point you do further testing or revascularize them. But so that's helpful. One interesting question.
Excuse me, Dr. Mills, before we continue, I just wanted to alert the attendees that we will launch the post-event test now. As with the pretest, we do ask that the attendees have to scroll through all of the 18 questions, and you'll only be able to click the submit button after you answer all of the questions. This will be followed with a final survey 60 days from now to gauge and evaluate if the guidelines were easy to translate into daily clinical practice. Thank you.
Yeah, two great questions in the chat. One's from Martin Fox, who I think is joining us from the UK. Ask about, have anybody used Wi-Fi to triage patients for referrals? So I'll let some of the other panelists address that. We actually used Wi-Fi at our institution when COVID first started. And we never got to the point where we could not do any procedures. So we weren't hit as bad as some places in the UK. And even some places in New York, I think, were hit like that, where there basically was no capacity to do anything that wasn't a truly life-threatening emergency. But we used the Wi-Fi to drive which patients would get into the hospital during COVID, and that was actually pretty effective. We pretty much only took care of Wi-Fi 3 and 4 patients in the house, mostly 4s, and the amputation rate was higher than our minor amputation rate was higher than it was in a corresponding time frame a year before, but not when you factor it out by Wi-Fi stage. I think Wi-Fi staging would be an ideal way to use for the hub and spoke system that a lot of us have talked about. So everybody can't come to the center and every patient doesn't want to. To my knowledge, I haven't seen any big studies on that. Have you, David? But to me, that would be an ideal way to use telehealth, for example. Like, one of my focuses in the SVS for the next 2 years is to try to figure out how to improve regional vascular care. And so you have to work with different communities, and you can't send people 4 hours away to see clinic once a week. That's not efficient. But telehealth may be a way to do it, and trying to develop a triage system. Have you been doing that in LA? David, you've been starting a program now in LA County. So talk about that.
In fact, on Friday, we have another meeting. We have this county-wide now working group across, so it includes UCLA, USC, but really it's our Department of Health Services, LA County, and all of our teaching hospitals. And it's a pretty substantial effort because you have 10.1 million folks, and it's a zip code lottery here, 10-fold variation in amputation depending on where you live, just and what zip code you're in. So it could not be more diverse, and in terms of type of care. And yeah, we are now working to kind of create a system, and every hospital is a little bit different because they all have different skill sets, but they virtually all now have kind of toe and flow. Thankfully, that's improving now. And so creating a consistent way of assessing these patients is the primary goal of each one of these. And it's really exciting to see what's happening, because Wi-Fi is kind of at the center of it. But it's really, I mean, look, classifications come and they go, but the ideas stay, right? And so the ideas are, what we had talked about, and it's really, a common language, and these languages change over time.
Yeah, part of the driver behind Wi-Fi was to try to get a language that we all spoke in this space. So vascular surgeons had Rutherford and Fontan, but if you look at them carefully, they were never intended to be applied to diabetics, and they were pure ischemia models. It was like you had a faucet that was dripping down to the foot, and the only factor that influenced outcome was how much water you could get through that faucet. Yep. And that's probably true for patients who are smokers and have old school vascular disease and don't have diabetes. And you turn the faucet back on, and unless it's already dead, it'll come back. But it's not the same thing with diabetics. So the idea was, just imagine a conversation you had before Wi-Fi, and you may still have. You get a call about a diabetic foot ulcer, and so you pick up the phone. What do you got? I got a diabetic foot ulcer. What is it? Well, it's an ulcer in the foot of a diabetic patient. And then you start having this discussion, him trying to describe it or her, and you don't get anywhere, right? So if somebody tells you it's a wound 2, ischemia 3 based on toe pressure of 25, and they have, a grade infection 2, right away you're going to admit that patient. They're going to get antibiotics. If the antibiotics don't resolve the infection quickly, they're going to get drained, and then they're going to get a prompt revascularization, right? So that it changes the whole conversation. So that was kind of the idea behind it. And like David says, the languages will change. I mean, Wi-Fi won't last forever. It'll be modified by somebody, or our patients will change and force us to modify it. That was what somebody asked, is could we make it simpler? Well, I think Alina did an elegant job presenting that, because the app really, I don't use the app a lot because I use that table because the color codes on the table I thought were interesting because it kind of green means go and red means bad and orange means caution and yellow is be careful, but you can go ahead if you're double checking things are okay, right? But the app makes it really simple. And if you don't remember all the little classifications, when you pull up that grade, it tells you what to look for. So that's the part. And I think the other question was to make it simpler. I think the 2s and 3s overlap. So if you look at almost all the published data, the amputation risk at 1 year is markedly different for the 1s and 4s. The 4s are even worse than what we used to call CLI. And the 1s, almost none of them get amputated if you provide minimal care. But interestingly, on the 2s and 3s, the wound healing times separate out really well, but the amputations overlap. And I think that means of those 64 boxes, we have some of them in the wrong category. But I think it's going to take more detailed study to figure out which ones we should shift around. And it could be we really only need 3 categories. It could be some of the 3s should be 4s and others of the 3s should be 2s, and we'll end up with mild, moderate, severe, which I would like better because that's kind of simpler than non-mild, moderate, and severe. But right now we haven't really done that. The other question for Dr. Azuma and Dr. Misra, Peter Schneider asked a good question. You do a complex endovascular revascularization. Can you detect small vessel embolization on either ICG or perfusion angiography? Have you all seen that? Dr. Azuma, why don't you go first, and then Dr. Misra, please.
I can't find your question.
The question was, do you use indocyanine green? Can you detect embolization based on that might not be obvious on angiogram? We all know that sorry feeling when you do something proximally and you get to look at the foot and it's not the same as it was when you started, so that some angiograms can pick up really bad embolization. But can you pick it up if it's more subtle on your intraoperative measurements?
Yeah, so that some patients are referred to the cardiologist after EVT, failed EVT. And then we do a bypass surgery. At that time, we do angiography, so that the different, that the small branches are disappeared after. So that's a kind of things that we can often see. But I'm not sure ICG can detect the small embolism, but we notice that the small branches are, disappearing. Yeah, that's it. Thank you.
Dr. Misra, have you seen that when you use perfusion imaging?
Yeah, great question, Peter. I think it's very hard to see it because you're looking at the revascularization effects and also distal embolization. So you're going to see very subtle changes that may not be that obvious. And so I don't think we have enough data on that, something to consider as we move forward with this technology.
Let me ask a sort of a follow-up question what Mike Conti was saying earlier. So you drain the foot infection, big plantar incision. You do an open surgical revascularization, and you wind up with massive post-revascularization edema. So when in that course, now we have patients that'll maintain really tense edema despite our best efforts for weeks, if not months. When do you restage? And then I would ask Dr. Misra, what's the best imaging in the setting of severe edema? And then David, I would ask you, how does it change your management of the foot when the foot is just a swollen, extremity?
We'll start with Dr. Misra because I'm waiting for what he wants to say.
sausage toes and swollen feet. What do you do with them?
I thought we were going in alphabetical order,
We'll get to the
David.
cankles in a minute once we have Professor Misra talk about how we measure it.
Yeah, so I think that's a very good question. I think the role. So I'm assuming creatinine is normal, and
Right.
And we're assuming this is not DVT and it's all related to the surgery. I think TCPO2s are going to be hard. We would have a difficult time with that. I think TBIs or toe pressures may be a reasonable way to go, depending on how the toes look. And then obviously ABIs may be difficult to elicit. So finally, you may want to go to invasive imaging or CTA to see if the runoff, et cetera, is okay. So I think that would be the decision tree I would make, or decision. If there's no soft tissue infection or osteomyelitis, I don't know that there's a role for MRI, because that would help you if you're wondering about an underlying infection in the postoperative area.
Yeah, well, so I think, and by the way, if we're going to be talking about imaging, at the risk of being heretical following a radiologist, I'll say my favorite medical acronym is victim of modern imaging technology, or VOMIT. You know, I mean, because I think very often, you know, we get these kind of consults, and I know, Sandra, you probably have to deal with them on the non-interventional portion of your life, where you're saying, well, why is this person even ordering this test? And then we get the patient where we have to where we have to treat something, and we go down a kind of a therapeutic and a diagnostic rabbit hole. But for these patients, specifically for the question about edema, look, if the patient has unilateral edema and it's not a DVT, and it's not, we then will think about Charcot arthropathy, which often happens, or it sometimes happens after a revascularization, and it's something that is often ignored, but we see it not infrequently after after some bypasses. You should be aware of it. Just kind of one of those pro tips. The other thing is changing our management. We are pretty aggressive about how we try to get rid of that edema. We have just absolutely, positively world-class physical therapists, or if you're British, physiotherapist, led by Stephanie Wolfel in our unit, and she's so we aggressively will kind of be milking that edema out of there with our PT and our OT unit in a real aggressive kind of lymphedema type of manner. It does change how we fit patients maybe for final shoe gear. So we may be modifying the offloading a little bit more in a more finite way before we get them into final shoe gear. But we really want to just be aggressive about this, and assuming that we're not, forcing too much fluid back that's been third spacing, and we're not putting the heart in any greater strain, which is relatively rare.
Thank you.
As somebody asked about the app, you shouldn't have trouble finding it. So I just Google SBS IPG and it comes right up, and you download it. You can put it right on your phone. It takes less than a minute. And I use it. I have our residents use it. We use it a lot. It's pretty simple. And it also has the other guidelines on it. It has other risk calculators, which we didn't talk about today. So next session, I think Dr. Conti will address, the anatomic staging system that's on the app. Also, we have a mortality predictor, which we basically broke down into low and average versus high risk for patients with CLTI based on a BQI database. That calculator is part of the app. Also, some of the venous calculators for venous ulcers, those are also on the app. And I believe some of the aortic disease ones. So they're not all limb salvage centric, but all the limb salvage stuff is on there.
I don't know if we have a minute to just talk about when and how to use Wi-Fi longitudinally in terms of, restaging. So, the guidelines support or suggest that for patients who are at lower risk or intermediate risk, often the initial treatment is wound care and follow-up assessment to see if there's improvement. And also there are, obviously a lot of David's colleagues may be working in relationships where people are referring back and forth, and they send a patient to a vascular specialist who gets a procedure, who says, okay, everything's great, sends them back, and then what? It doesn't look any different. So I just wonder if you guys could talk a little bit about how you approach restaging over time to see if patients are going in the trajectory that you want.
David, you want to start? Then maybe Arlena. Why don't you start, Arlena?
Yeah, how about Dr. Quiroga?
Yeah, we talked about that a little before. And I don't have like for other diseases like a known like every 3 months or every 6 months restaging. For me, what we have been doing is mostly when the patient is not progressing as I will expect. Like if the patient have good flow or the infection was controlled, I will expect that infection to get that wound to start shrinking or that flap to look great. And the same thing with my podiatrist. If he's seeing something that he's not happy, he will come back and say, we will restage and stuff like that. Maybe we should repeat the angiogram. Even the ultrasound is looking good. Maybe we should go back to do a duplex to restage this patient and see where the top pressures are. And I don't know if we should be doing something more scheduled, and I would like to know if people are doing this like we do with other surveillance projects. We don't use it as surveillance. We use it as a continuing assessment of the patient. And the patient is doing great. Honestly, I never use Wi-Fi again. I don't know, David, what do you do?
Once it's healed, you don't have a wound anymore. So they are a CLTI patient. So David can address this a little bit, but 50% of these patients recur or get a new ulcer within 5 years, and virtually 100%, if you look at Moorbach and others data from Germany, get it by 10 years. So we have a conversation now with our patients, even if we do a celebratory salsa dance like we did with that lady in our clinic, that's not the end of the story, especially for somebody like that, but even for somebody with a trivial ulcer. So we do, I'm sorry, go ahead.
Sorry. No, that this is for one limb, and it's not unusual to have patients with different Wi-Fi in each limb, and you have to be following both legs. And especially if one is not going the right way, don't forget the other leg that down the road may be the most important, the one that you really want to salvage. So that's the other thing. It's not that the patient is this Wi-Fi classification, it's the patient right lower extremity is this Wi-Fi and the other one is this. Remember to always do both legs.
For those people that have to, so we do our vascular surveillance, we do based on the procedure that we did and its expected failure mode. So for vein grafts, we pretty much still follow the classic vein graft surveillance protocol. For endo, I do differently. So I always get the first clinic visit usually, which is 1 to 2 weeks if it's a simple wound. They get toe waveforms and pressures if they have toes. If they don't, they get a duplex with pedal acceleration time. And I'm really paying attention early. So if I know I did a long, complex, multi-level endo reconstruction because there weren't other good options, then I know that that's highly likely to fail within 3 months, if not 6 months. So those patients I'll often see together with one of our podiatrists. And we look at the wound together. We alternate who the appointment's booked with, so they don't get billed twice. But we'll frequently pop in the other room. You know, if they're on a Dr. Ross day and he's looking at the wound, I'll pop in. And even though they had a formal vascular lab study a month ago, I might just grab the Doppler and listen to where I know my best signal should be based on what I did. And sometimes we'll get another study because you know what, the wound doesn't look any better than it did 4 weeks ago. And that perineal signal that used to have a great upstroke and be biphasic is now doesn't have such a great upstroke. And I did a TP trunk angioplasty and maybe that's going down. So that's how I use it. Once they're healed, we stop getting duplexes on most endo patients and we just get toe waveforms and pressures. But if they're adequately offloaded and don't have a foot ulcer, I don't treat them based on their toe pressures, but it lets me know they have recurrent disease. And if they have a low Wi-Fi grade, I mean a grade 2 or 3 ischemia, then I warn them that, you know, your foot circulation is not normal. You got to keep doing your offloading, do what Dr. Ross and Dr. Lipo tell you. You get a callus, come in. If you get an ulcer, come in early, don't wait because your blood flow is not normal. That's what we do. Vein grafts are, if you get them through their troubled childhood, they tend to last a long time. So we follow them pretty closely the first year. And then after that, it's every 6 months or a year for a while. That's what we do. Similar, Mike?
Yes, I think the bottom line is whether or not the wound is healed or healing. I think if it's not going forward, you've got to remeasure. And I think for the podiatrist, you absolutely can't just take it on faith that the revascularization is working. So it gives us a common language and an approach to kind of re-quantify. It's got to be going in a positive trajectory. If it's not, you got to start over and figure out which ring is the problem all over again, right?
Yeah. So the most common rings is missed infection or recurrent infection. Your revascularization is failing. or sometimes it's offloading. So there was a really good question. I answered it in the chat, but that one of the podiatrists pointed out that patient had motor neuropathy. So part of their care is going to be, how do you offload? So if the toe is flexible, there's simple ways to put that toe and protect it. But if it's not, and it keeps recurring, then one of the, the answer isn't repeated angioplasties for their mild SFA disease. It's they need to do something to help the foot deformity. So if you can't passively offload the foot, you may have to do a really good endo intervention so you can do something to correct the toe deformity. But the offloading is really important. So when I see a patient who stalls or recurs, I mean, I restage him in my head. So I double check, is my revascularization still doing what it's supposed to be doing, and how do I know that? And all of us have seen these patients that seem to be healing, and then all of a sudden they get worse. So the biggest Wi-Fi jumps I've seen are usually infection grade. They can go from a relatively low Wi-Fi limb classification, and all of a sudden they explode. It's usually from infection. And when you drain them, sometimes they look perfectly happy. The wound seems to be healing. You do your revasc, everything's hunky-dory, and then all of a sudden the wound doesn't quite close. That can be undrained infection. The infection has a way of not going away quickly. So that's my experience anyway. And then offloading is really important. So that even if your revasc is working and they're low ischemia grade, they need ongoing foot care, just for what the question was about, to make sure their foot deformity is not causing new ulcers. And your comments, David, on that?
Yeah, you already hit it. I think there's only one of 3 or 4 things that could be happening for maybe 90, 95% of the patients. What am I missing? And you have to cycle through this every, it depends on the acuity of the problem, but at minimum every few weeks. And is there a occult infection that I'm missing? Is there occult ischemia that we're collectively missing? And are we not taking something off appropriately? Are we not debriding or offloading well enough? And then lastly, is there something systemic that we're focusing too much on the toe and not much on the body that's attached to it? And are we, is this patient, like so many of our patients, are they basically in kwashiorkor? They have protein calorie malnutrition. Do we need to get we have our dietitians now in our clinics with us. Our RDs is one of the best additions we've ever had. And we blow this off. We say, like, just order some Ensure or something for the patient. That's ridiculous. That's often something that we're missing. Or it could be a pan-inflammatory syndrome that we're sort of missing, and there may be ways to address that, or other systemic problems. And I'm not even touching on, patients that are on renal replacement, which 40% of our patients in our kind of highest risk clinic are. So there's all of this complexity to add into our kind of algorithm. But it doesn't make it not fun.
On the vascular side, I would say that if a patient, if we've done an endoluminal revascularization, technically successful, and despite that, they go from stage 3 to stage 4, I'm thinking about doing a bypass like right away. I don't think you have a lot of time to play around. I don't care what the numbers say or what your angiogram looks like. If you're losing ground in the foot, you've got to do something more. And so to me, it's like, if the staging is, if it's going backwards, it's really concerning. You've got to move and do something different quickly. You can't just rely on the fact that your angiogram looked okay. It may not have enough hemodynamic impact to be changing the equation in the foot. It may be technically successful, but clinically ineffective.
Yeah, I think that's important. I mean, if the foot's going backwards, you need to, you do restage them, but then you really have to look really hard. Is there undrained infection, or is there, I remember one patient in particular, he didn't really have vein for conduit. So I kept going back and detecting to treating minor restenoses, and his foot would almost heal, then it wouldn't heal. And finally I went to the bedside with him when he got readmitted with Dr. Ross, and we started poking around his foot, and he had undrained pus with a little piece of tendon in the bottom of his foot. And I probably 4 of the 5 endo cases I did on him were unnecessary if I'd recognized sooner that I really had decent flow and I was really just undrained. But I think that's key. And the other thing, I think you can get inline flow on an angiogram and you don't get the hemodynamic response you'd predict. And that's more common with endo. And I think unless you IVUS everybody and you're really meticulous, you can have lesions that are over a long segment that just don't look that bad on angio, but hemodynamically, you're not getting enough blood to the foot. So I agree with Mike on those. If it's not infection and they've been offloaded, then they need more blood flow. And if you wait too long, you lose too much foot. So it's not, the guidelines aren't meant to be the Bible. They're not the 10 Commandments, but they're just to give you a language to talk to with your peers, and also a way to stage people. If you focus on, you've got these three things that could be going on: wound infection and ischemia. So how much of each do I have, and what's driving what I'm seeing in the foot right now, and which should I correct first? That's meant how you think about it. It's like a flight check. Before you take off, you check all the things on the little flight check, right? Well, don't take off on the foot till you've checked at least those three things. One other question, I think Alina was going to answer this, but we haven't answered it yet. Somebody asked about how, for those of you that have a center, but you reach out to the community, how successful have you been getting in some of your referring people to start using Wi-Fi and to kind of help decide when and who to send? And maybe Martin Fox can't speak, but he could type if he's on still. Alina?
No, I was just saying that that's a great idea, and I would love, and we're working in some community outreach project, and I will try to see how we can incorporate this in our referral patterns to vascular surgery, and especially just showing them the app and see how we can do it and explain that this is an easy way for evaluate the patient, but we have not implemented yet. Although I would love to do it.
Hey, I'll just add to that, because we're sort of in the middle of a lot of these things as well. It's a great point that Alina and Lisa also talked about, but we try to simplify it for referrals coming in, especially for ED, especially for primary care or for hospitalists. We just say, look, if there's a wound below the, basically on the lower extremity, just, send it in and we will triage it internally, or all the triage will happen internally. So we try to reduce the amount of complexity here, and ultimately complexity bias in decision making, and to do a lot of that internally. We will talk to them though in the ED for outpatient, for clinicians, about Wi-Fi, and to our patients, because they really get it when you describe that. But we don't actually want our patients, our other folks, to classify them any more than we'd want, a primary care doc, doing if they're sending someone to an oncologist to do a TNM on someone necessarily. We want to have it easier, not harder, yet improving the communication.
Yeah, there's subtleties. So a lot of questions have come up about what if the waveforms don't correlate with the pressures? Great question. So I rely on the waveforms a lot. So generally, toe pressures are more reliable than ABI, but even those can be falsely elevated. So if you see a pressure of 60 and the waveform's barely pulsatile, and the waveforms have been done properly, that's not zero grade ischemia, right? And so I worry that if we tell too many people to do this stuff before they send the patient, and depending on the quality of the person doing the test and how it's interpreted, it actually could delay patients getting sent for definitive care. So, but I think we're never going to get beyond some simple tests for screening in the community. I don't think, someone brought up pedal acceleration time. I think that's a really novel concept. It seems to correlate pretty well with toe pressures. There's a group of us that are trying to do a study on that. But to me, at least, that requires a pretty experienced tech, a duplex machine, and it's just not going to be practical for first line therapy. We're already struggling trying to get people just to get toe waveforms and pressures and ABIs. I think trying to get the PAT, I think that's a tool for the specialists. And I think it'll be really useful, and it also addresses the problem of what if they don't have toes, or a patient with a TMA with a new wound. Is it because they now have a motor problem with their foot that needs correction, or do they have recurrent ischemia? Well, you can't measure a toe pressure. What if their ABI is 1.6? So then what do you do? So I think PAT can help you on those. Any questions we haven't answered? I was looking at the Q&A. Let's see here. Looks like we've gotten to most of them. I think that's about it. Any final comments, Dr. Azuma? Anything you want to add?
So that, we in our country, we don't have a podiatrist. So that we are going to involve the nurses also in a community, the local area, to use the app, and then the Wi-Fi. Also, the sending just a photo of the foot. That's we are trying, but most of every day nurses are sending us photos. But that's a good thing, and the nurse network also I think we are trying to make.
So the toe amputations and TMAs, who does those mostly for CLTI?
Pardon me?
In your country, someone needs a toe amp after a revascular before, or they diabetic that needs a transmetatarsal amputation. Is that vascular surgery? Is that orthopedic surgery? Or is that plastic surgery? Or somebody else?
Yeah, maybe vascular surgeon or plastic surgeon. The major amputation may be orthopedic surgeon. Yeah.
Okay.
Yeah.
You guys have plastics, Dr. Armstrong. Are you working with plastics much, Dr. Quiroga?
Yes, and actually we are very collaborative with our plastics team. They're very, I mean, it's a great team, and they're very aggressive about free flap, very complex flaps and skin graft. And we don't do most of our skin graft. We will call either podiatry will do some of the small ones, or plastic surgery. I am very spoiled because my podiatrist share the clinic with me. We do clinic at the same time in the same place, so it's a typical complete collaborative sharing patients and doing that part. And we do have our plastic surgeons that are part of our limb preservation team as well.
Yeah, we did that in Arizona, and just putting the right people in the right place at the right time. So even if you don't have the patient scheduled on your list, it's not too inconvenient to walk over and meet somebody and look at their foot with your colleague, and it saves a lot of epic messages and stuff. And even if you don't get the workup done that day, they've met the vascular surgeon and they've got a contact between the two. I think that works really well. We do the same thing in Houston. So for complex patients, Dr. Ross and I see them together on one afternoon a month. But for simpler patients, if they show up in the foot clinic and they need a vascular person, there's always a vascular person having clinic day that they'll pop in. I think that really works. I don't think we have any other outstanding questions. Yeah. Did you want to go through Pete, did you want to briefly go over the results of the initial, so we did pre and post testing after session 1. So we have data on that. We'll get the data for this session for those of you that did the pre and post testing next time around.
Yeah, so these are the slides. I don't know if you want to speak to each one, or I can just click through them.
So this was basically, before the last session, was whether or not you used a classification system at all for CLTI patients. And the number went up from pre to post test pretty substantially. I'll just briefly summarize since we're ending up here at the end of a long day and some of you haven't eaten yet. Next question was, which system do you use? So small numbers of do not stage, not too many Wagners anymore. Most people are either using Wi-Fi or they still use Rutherford Fontan. Glass is newer, so I wouldn't have expected it to be as high as it is actually. And in the pre and post test indicates at least there's some interest in using glass. So glass basically, once you've classified a limb as having severe enough ischemia that revascularization might be a benefit, glass classifies the infrainguinal anatomy and tries to give you an idea of what the technical success would be and the durability of it. So that's the idea behind glass, which will be covered next session. Next slide. So confidence increased a lot. So only about 1/3 of people understood at all how to use a classification system before. And this is a group of people that are interested in this topic. And about almost 50% afterwards. That's pretty good after one session, I think. Next. Helpful in practice. So lowish numbers. Most people thought it was at least, well, vast majority thought it was either helpful or somewhat helpful or very helpful. Relatively small, so less than 20% thought it was not helpful, which I find interesting because otherwise I don't know how you treat this disease. Next. So very commonly used are ankle pressure, toe pressure, ABI. Pain is used, obviously. I think it's used by more people than checked it here because obviously ischemic rest pain. Not as common TCPO2 and ankle systolic pressure. To my knowledge, that's used mostly in the UK. Most people in the US don't use an absolute ankle pressure. Next. Is that the next one? I couldn't tell if it advanced or not because everything's blue and green.
Yes,
so
it
it shows some people became less confident in using it. Maybe the initial presentation confused them. So one thing I'd encourage you to do is read the initial Wi-Fi paper and then also read the GVG guidelines for glass. And if you have time, read them before the next session because they're both involved. And so it's a complex disease. So if you don't really read through what the intent was and how it's supposed to work, it makes it confusing. The app, as Dr. Quiroga pointed out, helps a lot because if you don't, as long as you remember to click on each box, it'll tell you what you have to answer. And if you're not sure which grade it is, it tells you that briefly. Okay, next.
And this is the last one.
So the vast majority of people use some classification system. That's what I got out of this one. And it increased after the test, which is good. That the purpose, again, is not to get too married to any one way of doing things, but at least to have a system. So this is actually a system that applies to our patients that we treat now. And I think you'll find next week, Mike has the hardest task because we have to figure out how do you take this Wi-Fi limb stage. You have a patient in front of you, you use the risk class calculator, then you get anatomic imaging, and then how do you decide what to do with that patient? Because they're all, one of the emphatic points of Wi-Fi is that even some lower grades of ischemia that didn't used to meet the grade for CLI might improve the patient's chance of keeping their limb if you revascularize them. So it actually broadens the group of people that you have to think about revascularization, right? So how do you put all that together? I mean, Mrs. Jones sitting in front of you with her foot ulcer that's been to 4 different clinics and decide, does she get a CTA? Does she get an angiogram? Does she get a bypass? Does she get endo first? Because what am I going to hurt? And so we probably need more time than the hour and a half we have, but I'm looking forward to how that gets put together by Dr. Conti.
Yeah, thanks, Joe. I'm actually still struck by how many people still use Rutherford for this disease. When you think about, you know, when we were training, they would call all these patients a quote non-healing ulcer. That's completely non-helpful.
Yeah, they were almost all 5s, right? Almost. So the Rutherford 6 means that a standard transmetatarsal amputation is no longer possible. So when I see people that say they did a Rutherford 6 revasc and all the toes healed, then it was never a Rutherford 6. It's just not. So most of the people that fall into the category we treat now are 5. So a 6 would include someone who gets a Chopard or a Liz Frank or a complex heel reconstruction, but they don't end up with a TMA. So, and those legs used to be thought to be unsalvageable, but for some patients, a Chopard and a Liz Frank for people that just walk around the house a little bit is a great result compared to a BKA. So anyway, I think this has been a great session. We started out, we got up to 150 at one point. We still have almost 190, I'm sorry, 90 folks on here. So this has been great. I think the reception indicates a lot of interest. Someone asked how we spread the word. I think the word gets spread by having more sessions like this with people from different parts of the country and the world and different specialties, and we talk about problems. So I think we probably do more of these, and especially as more data comes out, we can probably fine tune some of this. So be sure and you'll get another survey, which I think will come to you by email. So don't put it in the spam box. If it ends up in the spam box, it's from the SVS for the guidelines to try to answer it. I think we've come to a close. So I think this has been a great session. So Dr. Azuma, Dr. Armstrong, Dr. Misra, and Dr. Quiroga, those talks were great. I think having the talks recorded is really good because then we can spend more time on the discussion because we know how long the talks are. Each speaker did a great job, I think, staying on target. So went really well. I'm very pleased. And then thanks to John White and Mike Conti, our 2 other moderators. So the next one is when, Pete? What's the date for the 3rd session?
That is on October 10th.
October 10th. So
Thanks,
look for it.
Have a great evening.
Thanks again, all the panelists and all the participants and the SDS support crew.
Onward and upward. Take care, you guys.
But not offward.
Thank you.
Bye.
Thank you.
Not offward.
Yeah. Thank you. Great session. Thank you.